What on earth is this? Let's talk about arterial lines, or as we just call them, A lines or art lines for short. So, if you don't work with arterial lines very often, it can feel confusing and a little bit overwhelming when you've got all of these cords, but I promise it's not that bad. Let's break it down. So, there are three main parts to the arterial line. So, right here in the middle, we have the transducer. Everything branches off from this. So, we have our cable that hooks up to our monitor. We've got the soft tubing. See, this is nice and soft and flexible. This goes to our bag of fluids. It's going to be at 300 millimeters of mercury. And then this other part, this rigid tubing that you're not able to kink off or pinch, that is going to connect to the patient's usually radial artery. So it's going to go right here on the patient. And the reason we put an A line in is so that we can have a very close look at the blood pressure. Any patient that's on a pressor like norepinephrine or an epinephrine drip, vasopressin, things like that should have an art line in place so that we can keep a very close watch on their blood pressure. And it's not going to be affected by things like the blood pressure cuff scooting down their arm or when it pops off and you're getting the blood pressure of the ambient room. Here's a little bit more of a clear look at the setup of an arterial line. And when you're taking care of a patient with an art line, it's important that you also know what a normal waveform looks like. Here it is. So you've got that first big push. That's when the left ventricle is during systole. It goes and it starts to push that load out from that left ventricle. So you get a surge in the pressure, right? Because this waveform, it's just a graph. Your x-axis is time, your y-axis is measuring the pressure. And that first big push, that's systole, when the left ventricle is pushing the blood. Then it starts going down as that pulse kind of dissipates through the arteries of the body. And then you see that little notch. We call that the dicrotic notch. And that's actually when the aorta closes shut. So the left ventricle is pushing, 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 bam, and then the door closes. The aortic valve closes, and that gives one more little oof of pressure. Like if you were to slam a door right next to your face, it would whoof your hair up into the air, that little burst that it gives you. That's what the dicrotic notch is. And then the pressure continues to dissipate throughout diastole when the heart is refilling, and then it shoots back up with the next beat. Now, this isn't perfect. There are things that can cause this waveform to be incorrect. Just like a non-invasive blood pressure cuff, if it slides down, it's on the patient's elbow, or if it's on backwards, if it's fallen off of the patient, it's going to give you incorrect readings. That can happen with the arterial line, and you need to be able to recognize that. We can have overdampening. So overdampening is when we have something that's muting the signal as it's traveling from the patient to the transducer. So if you've got that line in the patient's radial artery and their arm is bent over, that's going to kink the signal. If you have bubbles in the tubing, could kink the signal. If you've got a clot built up on the end of that catheter that's in the patient's arm, you could have some over dampening, and that's going to give you a falsely low blood pressure reading. And if you had that happen, you might be like, "Ooh, I got to turn up my pressors." In reality, it's just a bad reading and the patient's blood pressure isn't low. So you can perform a fast flush test. Hang on. We're back. I dropped it. But you can perform a fast flush test by pulling on this pigtail, right? So we're not infusing anything. We're not hooking medications or blood products or fluids up to this to infuse like we would a central line. No, this is just to monitor. Now, I did tell you, this end is going to be hooked up to a bag of fluids with a pressure bag set to 300 millimeters of mercury. That's just a reference point for the transducer to be able to compare, okay, we know that this side is 300 millimeters of mercury, and it compares what it's hearing from the patient, and that allows it to spit out that reading. But every once in a while, when you pull this pigtail, or there are some brands that like you squeeze the cassette, it opens up the floodgates from that 300 millimeters of mercury fluid bag and goes and gives it a little fast flush to help clear the line of any bubbles, or if you've got a little bitty clot there on the end of your catheter. Additionally, make sure the patient's arm is straightened out and positioned appropriately, and that one of the most common causes of this is your transducer isn't situated with phlebostatic axis. What the heck is a phlebostatic axis? Look, we want this to be in line with what we're actually measuring, and that's the pressure that's being put out by the heart. So we line this up with the patient, line this up with the patient's heart. In transport, if I'm taking this patient on the helicopter, I line it up with that 4th to 5th intercostal space. Here you go. Phlebostatic axis, 4th to 5th intercostal space at the mid-axillary line. So 4th space and middle of the armpit line. And I actually tape it to the patient. Now in the ICU or in the emergency department, we have this on a little holder on the IV pole, but it's not going to work in transport environment because we're going from the hospital bed to our flight cot, out to the helicopter, put them up and put them down, and we're constantly moving. And so it's important that you keep that loaded into place when you are in transport. So the opposite of overdampening is if you have underdampening. Here's a waveform. You can tell right away something is amiss, right? That waveform is hyperdynamic. It's going to give you a falsely high blood pressure reading. It might tell you, holy heck, your patient's blood pressure is now 210/95, and you're like, whoa, I got to slow down my pressors. And in reality, it's just an underdampened waveform, and your pressors still need to be turned up. So some things that can cause this: if the patient is in a ventricular arrhythmia, that can cause underdampening. If there's catheter whip and it's flapping around there, so make sure your patient's arm again is positioned appropriately. You can do another one of those fast flush tests, and that'll just kind of uh, make sure everything is clear in the line. We don't have anything interfering with it. We want to make sure our transducer is where it should be, and that our pressure bag is set to 300 and it hasn't all of a sudden accidentally been dropped down to 150, which when we're talking about flight physiology, this is where Boyle's law comes in, because that pressure bag that we keep around that bag of fluids is influenced by changes in altitude. So it's really important to manage all of these different things when taking care of an art line. Look, there's a lot more you need to know, but this is just Art Line 101 in about 6 minutes.